Hi, and welcome to the show. Rate and review at kevinemily.com/rate. Subscribe at kevinemily.com/podcast. Today on the show, we have Gary Call. He's a physician and healthcare executive. His Kevin Emily article is titled, Think Twice About Prescribing Opioids as First-Line Treatment for Pain. Gary, welcome to the show.
Thanks, Kevin. Happy to be here. Thanks for having me.
We'll get into the article in a little bit. First off, briefly share your story and journey to where you are today.
Yeah, so I went to medical school at the University of Washington in Seattle, which is where I grew up, and enjoyed that experience. Had an opportunity to go do my family medicine residency at the University of Utah. And I chose family medicine and really have enjoyed the career there. I really liked the interaction with people. I liked, the opportunity to get to know people over time and their families. And so, really have enjoyed being a family physician. Coming out of residency, I started working in a vertically integrated healthcare organization and joined the practice there. Had some opportunities to start doing some leadership type activities, both at the clinic level and then later at the family practice department and hospital level. So kind of got into that a little bit, enjoyed some of the administrative and business side of things. After doing that for a few years, kind of decided to broaden my experience and really wanted to get into the private practice world. So I started a small group practice with a couple of friends. So we had a 3-person practice in family medicine, pretty much full spectrum. We didn't do OB, but we did everything else and really enjoyed that a lot. Did that for a few years. And as I was working there, got an opportunity to get involved in managed care. So I had a friend who was the head of a managed care organization, and they needed a medical director just a couple hours a week. This plan was just starting. So started doing that, enjoyed that, kind of learned some new things that I didn't know. And so had an opportunity, and that expanded over time as the plan grew. Pretty soon I was working too much and I had to make a decision. Do I continue in my practice? Do I go into managed care administration full time? Decided to go ahead and do the business side of things, which was interesting and, like I said, kind of a new experience. So I did that for a number of years. Gradually had a chance to work at both the state and the national level in managed care. Learned all kinds of things about medical management, quality, pharmacy, just a really great learning experience, and had the opportunity to do a lot of things, learn a lot about the healthcare system. So I did that for quite a long time, and then had an opportunity to switch gears a little bit and get into healthcare technology. So currently I'm working as the Chief Medical Officer for Gainwell Technologies, and that's a company that provides healthcare technology that supports states as they administer their Medicaid programs. So I'm kind of in charge of all things clinical, but mostly focusing on identifying and recovering money from fraud, waste, and abuse, and also improving patient experiences and outcomes through a care management technology platform and some analytics that we also do. So, I've really been blessed to have a career with a tremendous amount of different opportunities and a lot of experiences, which I think has helped my view of the healthcare system. Also been really rewarding. I really love learning new things and having opportunities to do some different type stuff. So it's been great.
Now, you've been on both sides of the spectrum, obviously. You've been on the clinical side, you've been on the administrative side, and now you're in the healthcare tech side. So for those practicing clinicians who may not have your depth of experience, what are some misperceptions, would you say, about the administrative business side of medicine that you would want them to know about or clear up?
I think it's interesting. When I first went into managed care, a lot of my colleagues and friends said, "Oh, I can't believe you're going to the dark side." I thought about that. My response really was, I'm hoping I can make the dark side a little more light. And so I think as I got into administrative medicine and the business side of things, it really helped to broaden my perspective and help me understand more about the healthcare system and how it works and how it functions. I don't think we really teach people that. And I think when you start out and you're in training and you're just starting a practice and you're really just head down trying to make it work, it's unfortunate that you don't have a bigger picture, because I think if we understood how the system works and how to work with payers and how do hospitals work and how does a physician role at hospitals work, I think if we understood all those things, it would really help us as physicians to have a more meaningful experience and really enjoy things. I think sometimes physicians feel like they're victimized or just feel like they're captives of this overburdened system. And I think that leads to dissatisfaction and burnout, which is really too bad because there's so many exciting things that you can do in medicine. So I think, again, having that perspective has really helped me see the broader picture. And I think has really helped me understand that if we all understood the perspectives of the different players, whether it's the government, because I've worked a lot in Medicaid, so I understand, I think, to some degree what the government's trying to accomplish with healthcare, payers, hospitals, patients, advocacy groups. I've worked with all those groups, and I think having that experience and that view has helped me really have a more positive experience in healthcare and really a really enjoyable career and not maybe feel that burnout and victimization that I think so many physicians feel right now.
So give us an example, a brief story or an example of something that a perhaps burnout clinician, you wish they could better understand something from the other side that can help their burnout. So give us an example of some of those misperceptions that may arise.
Yeah, so I've had an opportunity to do a lot of work in medical management, which includes prior authorization.
Yeah.
So that's probably one of the biggest thorns in the side of physicians everywhere. Like everybody hates prior
Yeah.
authorization, but having seen it from the other side, I know when I first went to the managed care organization, I thought, oh man, the physicians in our community are so awesome. Like this is going to be a breeze. And some of the things I saw, quite frankly, shocked me. People requesting services that had no medical justification, weren't following any practice guidelines or best practices at all. And so I think what I learned as a physician was take the things that you typically do in your practice, especially those services that might require an authorization, and learn about that and really learn what are the best practices and line yourself up to be data driven. I think that helps. And again, it's always going to be a burden, but I think if you know what it is the managed care companies expect, and again, from that side of the fence, we're really just expecting people to follow data driven
Hmm.
practices and best practices that are published out there. Then I think it's an opportunity for people to maybe make that less of a thorn because they're prepared and they know, what the expectation is. And I think it'd just be a lot easier. I think people will feel less burdened by that process if it doesn't feel like an enemy, but you're just both working together on data driven practice.
All right, let's move on to your Kevin MD article titled Think Twice About Prescribing Opioids as First Line Treatment for Pain. Now, tell us, how did this article come together?
Yeah, so one of the things I do at Gainwell is, we talked about the work we do with state Medicaid
Mhm.
programs. We have a ton of Medicaid claims data. And so we were trying to think, how can we take that data and make it useful to improve and then tackle some of healthcare's most challenging problems? So we went to some of our clients and we said, would you allow us, if we de-identify the data, would you allow us to use this database for research purposes? And we're grateful that some of our clients agreed to let us do that. So then we took that database and we reached out to some academic partners and said, hey, we've got this research database. We'd love to work with you on some academic research that's geared towards, you know, things that the industry can use to get better and solve some of these big problems. One of the problems I was really interested in at the time and still am is the opioid problem
Mhm.
we have in the country. And how do we tackle that? And how do we get ahead of, how do we identify at-risk people? We've seen how hard it is once people start to have a problem with opioids,
Yeah.
how hard it is to treat that and to solve that problem. How do we get ahead of that and identify people at risk? So that was something I was particularly interested in at the time. And luckily, one of our academic partners, that kind of resonated with them. So Dr. Tina Hernandez-Boussard, who's at the Stanford University School of Medicine, she and her research team have been doing a number of studies on opioids using Gainwell's database. So it's been really interesting to see some of the fruits of their research. So the article that I wrote for your blog was really based on one of the published articles that they had. And there was some really interesting stuff there because I would have thought that the main risk factor for opioids was continuing to prescribe over a period of time. But what they really found as they did their predictive analytics and built the risk model was it was actually the initial prescription that seemed to have the most influence on whether somebody developed chronic opioid use. And it was characteristics, things like the number of pills that they were given, the duration of treatment, the choice of the drug, Not surprisingly, long-acting oxycodone was a high-risk factor. But I think something that was very surprising and would surprise a lot of physicians was tramadol was also a high-risk factor. And I think that was interesting to me because I think in the industry, a lot of people are using tramadol
Hmm.
as an alternative almost to opioids, thinking that it's lower risk. So that was kind of a surprising finding, I think, from the study. So I think to me, one of the goals that we have in doing this research is to find things that not just academics, because so much of academic research just sits on a shelf somewhere, but we're hoping to influence practice and provide solutions. So I think this offers an opportunity for physicians to really consider their initial prescribing of opioids and really think about that. I think when we come out of training and in our early years of practice, we develop these prescribing habits. And I think people kind of just follow those. And so I think as you consider what you should do differently, maybe I think this is an opportunity to think about that first prescription. Do I really need it? And if so, what duration, what dosage, what drugs am I going to choose? I think this study really offered that opportunity. And I also think it gave us an opportunity in the industry to use this research. I mean, at Gainwell, we're using this in some of our analytics products and in some of our patient outreach and care
Hmm.
management products. So again, that tie-in between academics and industry is so critical. And so really feel fortunate to have started doing, research with the data that we have.
Now, when you talk about that initial prescription, what were some typical doses, number of pills, length of treatments that would be associated with that patient perhaps having a problem with opioids in the future?
I think the biggest thing was, and I don't remember off the top of my head, unfortunately, the milligram equivalents or the morphine equivalents of the dosages, but we did find that a prescription that went for more than 10 days
Mhm.
was a significant risk factor on that initial prescription. And I also think that, as we looked at that drug choice was really critical. Like I said, it seemed like long acting opioids and, as I mentioned, surprisingly, tramadol were two of the risk factor drugs that we saw in that prescribing. So again, I think just being judicious and thinking about it and not being the surgeon that just always gives, people, 30 oxycodone or whatever after a procedure, kind of think about what you're doing and get out of some of those habits that maybe we've developed. I think that's the opportunity that I see.
Now, did the study differentiate between the setting where the opioid were prescribed? You did mention a post-operative setting versus a primary care setting.
Didn't really differentiate there, but it did look at people who were opioid naive, meaning they
Mhm.
hadn't had any opioid prescriptions in the previous 6 months, and then identifying people who had opioid prescriptions still ongoing for 6 to 9 months after the initial prescription. And that was about 30% of the population that we looked at. And that's out of a study population of about 180,000 people. So really a much higher percentage than I would have thought went on to have chronic opioid use. And like I said, it seems to be that initial prescription.
So you mentioned opioids like OxyContin, oxycodone, as well as tramadol. Did it look at any other opioid type or habit-forming type medications, something like a gabapentin or benzodiazepines, for instance?
Yeah, this study did not look at those types of medications. It was really focused on opioids. So we didn't look at those, and maybe that's some steps for other research. I know we continue to work with the Stanford team and hoping to do more research along these lines. Again, trying to focus on it's so much easier to prevent people from having a problem than to address this problem afterwards. And I think we've all been touched in some way by the opioid crisis and the overdose deaths. And so we're really trying to look for ways to have an impact and make a difference ahead of time.
Any other risk factors that particularly struck you other than that initial prescription?
I think those were the main things that really struck me as meaningful. And again, I think that's counterintuitive. That's why I think it's so important because again, as a prescribing physician, I would have thought it's maybe the second or the third time you go to the
Mm.
opioids that really develop that habituation and the problem. And that's not what the study found. So super interesting study, I thought, and very applicable to our practices.
So, what's the next steps in terms of studying the opioid crisis using Gainwell's data?
Yeah, I think continuing to look at things, we have some ongoing studies about, adherence to treatment. We're doing a study with a university that talks about how does the movement of Medicaid patients affect their ability to adhere to opioid treatment, for example? So I think we're looking at a broad range of things, but again, mostly focused on how do we prevent it. So kind of looking at some other aspects of that. And we're also using our research for other things too. I think we're looking at our data. We're doing some studies with Southern Methodist University on hospital readmissions, for example, and what are some risk factors that would help us predict those. We're doing some studies with some Australian universities who have expertise in geospatial mapping and looking at social determinants of health and how does, for example, we have a thing that we've looked at with diabetics and mapping good food sources versus like fast food outlets in certain areas where the underserved populations live. And it's quite striking. I mean, we had one study that we did in a state where within the highest concentrated areas of Medicaid patients with diabetes, there was 100 fast food outlets and 0 grocery stores. So it just gives us an opportunity to address some of those kinds of things. So I think Gainwell's data is really something that is an opportunity to understand the Medicaid population on a much bigger scale than we've had before. And most of the academics say it's kind of a one of a kind database opportunity. So we're excited to be able to continue that research work.
We're talking to Gary Call. He's a family physician and a healthcare executive. His Kevin MD article is titled Think Twice About Prescribing Opioids as a First Line Treatment for Pain. So, Gary, I just want you to reiterate in terms of the clinical repercussions of the study. Just tell us some of those as well as the take home messages from your article.
Yeah, I think the take home message from the article is just, I think in everything that we do, be thoughtful, don't be habit driven. Because I think as I look at some of the data and some of the ways that the opioids were prescribed, it just looks like people are just doing things out of habit. So I think be thoughtful and be conscious of that first prescription. And A, do you really need opioids? B, if you do, what's the minimum I can do? And again, we all walk that fine line between controlling patients' pain. So we're not saying don't prescribe opioids, obviously. And that actually has been a little bit of a problem with the opioid crisis is people are afraid to even prescribe them at all. But just be thoughtful, be data driven, use best practices. But think about that first prescription, I think is really critical. And I think that probably applies, Kevin, to pretty much everything we do in medicine. It's so easy to get into a habit and this is the way I do stuff. And I think we just always need to take an opportunity to evaluate and rethink our practices and make sure that we're following the data, we're following best practices, and we're really seeking those out.
Gary, thank you so much for sharing your time and insight. Thanks again for being on the show.
Yeah, thanks, Kevin. Really appreciate the opportunity. Thank you.